Good morning, everyone. My name is Elizabeth Carpenter. I'm a resident at Brooke Army Medical Center. I want to thank SAGES and my co-authors for the opportunity to present and all support. Today we'll be discussing meeting the new Commission on Cancer Operative Standards, which was a single institution pre-implementation review that we performed at our institution. And we have no disclosures. So in June 2020, the ACS launched the Commission on Cancer program, the Cancer Surgery Standards, which was a new program dedicated to improving the quality of care for cancer patients by implementation of evidence-based technical standards for surgery. And this program has led to 6 new operative standards that have recently been developed and published, which focus on appropriate surgical technique and documentation in the surgery and pathology reports. And this is important because this is the first time technical aspects of an operation are tracked by the Commission on Cancer, which is required for all programs to maintain their COC accreditation. Specifically, new standards 5.7 and 5.8 make requirements for specific surgical technique and pathology-centric documentation in relation to rectal and lung cancer, which will be the focus of this discussion. So standard 5.7 dictates a total mesorectal excision for cases of mid to low rectal cancers, and they also dictate a synoptic format for pathology reporting. And then standard 5.8 deals with primary lung cancer as well as appropriate lymphadenectomy, and again dictate a synoptic pathology report for that as well. So the objectives of this project was to establish our institution's current adherence to standards 5.7 and 5.8, primarily before these standards go live. So compliance begins with 2021 cases, which will be reviewed during 2022 site visits by the COC. And the goal was to identify actionable deficits in documentation for targeted intervention in preparation for upcoming site visits. Given that this audit was performed before compliance was required, we hypothesized that our compliance would be low, but that we would be able to identify deficits and make targeted interventions. So we conducted a single institution chart review from 2018 to 2020 for those procedures meeting criteria for COC standards 5.7 to 5.8. We identified cases through the surgical scheduling system and created a list of contributing elements to each standard. And then all operative and pathology reports were reviewed for each applicable case. We included all cases of mid to low rectal adenocarcinoma as well as primary lung cancer. We did notably exclude any non-anatomic rectal resection, such as an endoscopic submucosal resection or polypectomy, as well as any non-curative intent or palliative procedures, as the standards will not apply to these cases. So we reviewed all pathology and operative reports for the following elements to include cases of a near complete or complete TME or mediastinal or hilar lymph node resection, as well as TME quality and lymph node stations collected. We reviewed a total of 110 cases and ultimately determined that 48 cases met criteria for standard 5.8, as well as 12 cases which met standard 5.7. We see here that while documentation of a TME was performed in 75% of cases, there were instances where the documentation was incomplete, ultimately resulting in a compliance of 58% for standard 5.7. And then for standard 5.8, ultimately 35% compliance was determined based on documentation of adequate lymphadenectomy. So we brought these results to our local cancer committee meeting and assimilated the deficits, identifying that lack of compliance to standard 5.7 was primarily attributed to lack of documentation, whereas lack of compliance to standard 5.8 was ultimately due to inadequate lymphadenectomy. Upon review of operative reports, we determined that this was due to inadequate sampling of the appropriate hilar and mediastinal lymph node stations. So as I mentioned, this was consolidated at the local cancer committee meeting, and then we discussed these with the department leadership, brainstorming potential interventions that could be performed, and we also assimilated educational material to provide to cardiothoracic and colorectal surgeons, as well as the pathologists at our institution. And then upon reassessment prior to each quarterly local cancer committee meeting, we identified 100% compliance. We performed an ongoing quarterly review and notably identified a dip in compliance in the beginning of 2021. We were ultimately able to identify one new thoracic surgeon who joined the department, and after discussion and dissemination of the educational material, we again achieved 100% compliance. So to conclude, we performed a chart review of 2018 to 2020 cases, demonstrating ultimately an approximately 50% or lower compliance to standards 5.7 and 5.8 prior to the standard going live. Standard 5.7 deficits were ultimately attributed to inadequate documentation, whereas for 5.8 there was inadequate lymph node sampling. But after primary intervention and reassessment, ultimately the compliance for each respective department was 100%. There are some noted limitations to this study. This is a single institution chart review of a short period of time with a small sample size. However, we believe that this gives some actionable steps for future institutions who may be desiring to perform their own review of their compliance prior to the site visits that are starting this year. We want to conclude with some lessons learned from our institution review. Notably, we would like to recommend that all institutions conduct a chart review to identify their own deficits, as this is the only way to apply targeted interventions to increase your compliance. We used a surgical scheduler and registrar to find cases applicable to standards. This is also a very high yield means of determining whether or not standards are being appropriately allocated. For instance, if a case is not appropriately earmarked as a non-curative intent procedure, this may be misattributed as a standard applicable case and ultimately lead to reduced compliance for the institution. We identified deficits in pathology reports and then proceeded to operative reports. This is, of course, a time-intensive review, and so we'd suggest starting first with pathology reports, identifying any deficits, and then proceeding to the operative report to see if there's a deficit in the pathology report, the operative report, or the both of them. And then just to conclude, educating in a blame-free manner and motivating change through shared interest and improved outcomes. It's, of course, a difficult topic to address with a surgeon whether or not his or her practice may need to change to comply with some of these standards, but we all have a shared interest in improving outcomes for our patients, and I think addressing this in that manner is the most efficacious. And then finally, reassessing frequently, as I think we demonstrated through our 2021 anecdote. There's turnover in the department naturally, and especially in the military, and so continued reassessment is very important so that all surgeons can get the education material and we can all work together to have an excellent compliance within our respective departments. So with that, I'd like to conclude and thank SAGES and my co-authors again, and we can take any questions.